more people coming. All right. Hello, everyone. Welcome to Med Talks. Some of you know me, some of you don't. They are here the first time. I'm Catherine Kunze, a clinical trial communication strategist. I specialize in cancer and rare diseases. I talk a lot about patient communication and how we can improve health communication in general. I also wrote 2 books and published 2 books lately about that related to cancer and clinical trials. MedTalks connects professionals, patients, and organizations to improve clinical trial understanding and trust. And if your organization would like to support this mission, sponsoring opportunities are available from now on. And now let's begin. I told you that I am very active and that I am authored or co-authored 1 book, authored another one. And through those books, I got in contact with Dave Chuter, and I am welcoming you here. I'm really glad. It's been very spontaneous. We had our very first talk last week, and due to a coincidence, we could meet this week already here on Med Talks. Dave, welcome to Med Talks. Would you like to introduce yourself a little?
Hi, good morning, good afternoon, everyone. I see a lot of familiar faces there, so hello, everyone. Yeah, I'm Dave. I had esophageal cancer way back in 2006 and been doing this kind of thing ever since then. So it's been a long journey, but it's good fun.
Right, so you're in the business for 20 years now.
Yes.
Would you like to tell us shortly what you did before? Because I find that very interesting.
I used to work in print management, print sales, print safety for food packaging and pharma products and labels. So putting ink on paper, that was my career.
Which again connects to me. And we found out that we a lot of connection points. It's very interesting how you meet people sometimes, and it just clicks, right?
It does.
So you are speaking out of the patient view of things. I'm here as the HCP/communicator. What made you being so active in this space, and how did you start about that?
Well, the trigger was myself having the cancer, and I was just looking for another patient to talk to about how I can live without most of my stomach. How can I survive? And there wasn't any support groups at that time. So I set up a support group in Guildford, still running now, monthly. So we're looking to celebrate our 20th year this year.
Wow.
And it was patients coming to that support group asking about the trial they've been invited to join, how that, is it good? Is it the right one for them? Are there other trials? And I had to get my head around the research on how I could help them make that choice. But it kind of just, that was kind of trigger this, looking for another patient to talk to, finding out all the trials that were going on, seeing that the patient voice wasn't in there. So I had to get involved. I had to learn. So it started off a brand new career at that stage, which is fun.
Someone here hasn't muted his phone, his microphone. It's I get some noises. Maybe you can check that you're muted. Thank you. Thank you, Dave, for this first introduction. So how did you go along? I don't even know where to start. You have so many initiatives going on. You're a co-founder of so many things. Maybe you want to talk about, we do this chronically. What is your biggest baby of all those babies?
Well, my first sort of entrance into the research side was joining Swiss Cancer Partnership Research Group way back in about 2009. It was run from the Guildford area, covering Surrey, West Sussex, and Kent. And it was just a group of patients and researchers talking about research trials, looking at the lay summary, how they could make it easier, and just learning about the research. So that was my kind of start. That was the forerunner of the NIHR Clinical Research Network. And when we finished, about 2016, that started up then. So I became one of the first members to that. And it's just built on that, built from the local ones, just getting a little bit further out.
Right.
So it was a long journey from about 2009, 2016. It was kind of local, and then it slowly built up with the other stuff coming outside, externally from what I did then. Still part of the Research Champions group. I do miss many meetings. Sorry, Alan, I do miss them. But it's that's how I got into it. Then I chaired the OPA, Esophageal Patients Association. It's a UK-based charity for esophageal cancer and gastric cancer patients. I got involved with them, became treasurer, trustee around about 2015. I was chair from 2017 to 2020. And that's when COVID hit. That's when I retired full-time from work to do this as a full-time thing.
Wow.
So I got involved with DICE, Digestive Cancers Europe, around about 2018, 2019, with the original founders. I knew them, and I was involved just as a member then. But slowly, just a member, yeah, just a member,
yeah, right.
And from then I became vice chair 4 years ago, and then chair last July.
Wow, so, you are so busy.
It's fun. Fun.
I get that. And especially out of your perspective, being a patient and seeing why this is so necessary. At this point, before we start talking about BART, which I think is a fantastic thing as well, you created. You mentioned clinical trials, so I'm guessing you were on a clinical trial or several?
No, I wasn't. My treatment went I didn't even have chemo. I went straight to surgery.
All right. Okay.
It caught the cancer. They caught right early stages, and they said we'll go to surgery first, then we'll see if you need any chemo afterwards when we check your lymph nodes. But I was clear.
So all right. Well, that is great.
So I wasn't on any trial.
So what made you thinking about trials? Then?
Every other patient I saw, who came to the support group, were invited to join trials. So it was helping them for their journeys. That made me get involved. Yeah. Learning about research for other patients. Patient support is my big thing, and always has been, always will be. The support groups. I've got a huge support group network across the UK now with my esophageal cancer support, and that comes first. Whatever I do is patient support, and everything else I can do, if it has got that patient support in it somewhere, in the organisation, in the charity, that's why I will join.
That is amazing. That actually brings me to another point, which I wanted to talk about later. But let's. It's such a nice forward from you to introduction to this collaboration. You are one of the few that is always open for more collaboration with many other groups. And I love that. I love that you don't think, this is my thing and you do your thing, because that is, in my opinion, the only way it works, especially in networks like this. What brought you to this? Were you always like that, or was that something you learned along the way?
I think it's something I learned along the way. It's seeing, when I was looking for resources for other patients, I was going from one charity to the other. They all had this very similar resources, information, but it's worded slightly different. And it suddenly clicked that everybody's doing the same thing. Everybody's duplicating the same resources, the same information for patients, the same research in some places.
Yes.
So it was, for me, I would love to have an umbrella organization, a patient organization, which covers every cancer group, something they can feed into and we can feed out to
Yeah,
every
this way it's
organisation.
much more effective also, right?
It's much more effective, and it's going to be, everybody's going to be working together on the same stuff and not duplicating. They're not duplicating the same recipe books, the same patient info packs. It's just,
and it's also easier to spread information, right? If you're,
it's easier to spread information if you know everybody else who's doing the same thing. Yeah, and there's just too many silos out there. It happens not only in research; it happens with charities. I understand charities, they're trying to safeguard their own funding, but I think if they all work together, there's got to be plenty of funding for everybody. And the same with pharma.
Exactly.
Yeah, and it's the same with pharma. We find they're doing a lot of work. Same drugs often. They haven't got the patient voice on there, or they haven't quite made it yet. And for me, there's just too many silos. Everything needs to be in the same place.
Yeah, it must be much better, especially these days. We live so global, and we have the internet, we have resources that make it possible to really have that umbrella organization that then spreads the news to everyone. And I would love to be a part of this and to just help bringing this forward. I love organization and stuff. But now let's, you said patient voice, PPI.
Yes.
Something that I keep talking about. I had a podcast interview yesterday and I had to talk about it because I really love the thing that you are doing is like I put it like that you put researchers and patients into one room and then they have to figure out how to communicate with each other. Tell us more about that because I love that project, really.
It's one of the big things we do with ICPV, Independent Cancer Patient Voice. We're kind of that link between patient advocates, carers, people who want to get involved with research, and the researchers themselves and their organisations. You know, we do a lot of work with researchers, and we go into their labs, and we talk to them. We show them what we do. We let them know why we're doing it, and it's always always amazing to me how so many of those researchers have a story of why they're doing that research, and it's always something in their family, a friend, and it's always a big thing for them. It's the reason they got into that kind of research, and they suddenly realise that we're all the same people, we're all there for the same reason. To benefit patients.
Exactly, that's the point. What Keith and I were also trying to put through the book out into the world. People behind the clinical trials, they are just normal people. Yeah. They have stories, they have reasons why they do what they do. Even though we are in a very clinical, dry, maybe sterile field sometimes, but it is about people from people. So yeah, I really love that you're saying that. So how can I imagine that if I want to be taking part in the course as a cancer patient? Is it only cancer patients who are in the course?
No, it's anybody who's a cancer patient advocate.
Oh, okay.
We've had carers, we've had people from CEOs of charities who want to be there. CI UK a couple of years ago, they had their PPI manager there just to understand what we do as a patient. She runs the patient advocacy at Cancer Grand Challenge, but she's not a patient.
Interesting.
So she joined us. Last year we had Antoniella from Cancer Basin Europe. She's the CEO.
Oh, wow.
Yeah, she joined us for the week just to understand what we do and how we do it, and how she can take that back and work with researchers herself, in their
and how do the people find you? How do they find? I mean, this is unique, right? It's not like you have a lot of schools offering this.
It is unique. It's a one-off, once a year. It's I've always put adverts out beginning of the year to get people to come along. This year we got 20 spaces. We don't want to do any more than 20 because it's not interactive. But I've got 29 people on my books who are interested, and that's come from word of mouth. It's word of mouth now.
Yeah.
We're opening in Dublin this year as well. That's on the 23rd of August, I think. So that's
it's amazing.
I will be there to help them on their first one, but then they leave them to run it themselves. And we're talking to other people in Europe and in the US on how we can open up that next year out there.
Gosh, I love that. Tell me, what do I expect? Like you say, okay, Catherine, come and do that course with me. What would I be looking forward to? Well, like
there's quite a few graduates here actually. So
Peter would like to talk about it. Yeah, I love that.
Peter,
tell us, how is it?
Morning, Dave. Yeah, I thought I'd come
Peter.
and support you. Yes, the course at Barts is absolutely amazing. I'm trying to think of an analogy. I mean, you've got, as Dave said, you've got everything from CEOs. There was the CEO of somebody was there the year that I did it, I think in 2023. And you've got people from across the spectrum, advocates, ladies that have got different forms of breast cancer. I was representing prostate cancer, colorectal cancer comes up. Through the week, Professor John Marshall, who sort of runs the thing for ICPV, you go in, and by the end of the first day, I will tell you, you actually feel totally trashed because they just hit you. It's like doing an A level in a week.
Right.
So, but it's not, if you know what I mean, because you do the morning and then the afternoon you're in the lab, and then the following morning you're in the lab. And the way it was done, certainly when I was there, is you get the following morning, you'll get a pair probably from the team. And we are a team when you're doing that because you all help each other. They will stand up and they will do a review of the previous day. So it's my belief, I'm a retired engineer, but it's my belief that you've understood it if you can explain it. So everybody during the week gets an opportunity to explain what went on the day before. And some of it is instant, and that some of it you go into the other labs around the Barts Institute and QMUL, Queen Mary University London for everybody, and you'll do stuff. You do the pipetting. I think the first day, Dave, from memory, is you learn actually how to use the gauges, the measurements, and the rest of it by pipetting off water and stuff. But then you build them. Then they'll give you something that's apparently been genetically modified so it can't make you ill to work with. Dave's laughing.
Don't believe that.
No, I know. I came back with terrible ringworm. No, joke. But you know, so then you're pipetting stuff off, so you're getting the right amount of reagent, the right amount of whatever you're going to do. And then you get later on in the week, after it's had a time to cook, you'll go back and look at it under a magnifying glass, under a microscope, and see what you've done. So it's so well structured that by the end of the week, you don't realize just how much you've learned.
Yeah. That sounds amazing.
And for me, it's absolutely brilliant because I'm not going to take, this is Dave's turn, but I actually work closely with prostate cancer and different researchers. And one that I've got involved in is actually looking at how prostate cancer proteins move through the blood, invade bone tissue, and overwhelm it. And I've actually been able to proofread and support the doctorates that are doing that at the UK university.
Wow.
And the reason I could understand that so very well was because of what I'd learned in that week. And it depends on what treats John's got in store for you, because the week we were there, he took us into his lab and he showed us fruit flies. And I can't remember what the fruit flies were doing. They shouldn't be doing it in public, that's for certain. So they on all these odd sorts of things. And then we also did a visit to the Barbican Centre where they showed us the latest sort of way of trying to help support young people learning about stuff. I don't know if they still do that, but they have little treats that you can lay on. Was that all right, Dave? I didn't want to. I thought getting it from an attendee.
It's wonderful. It's wonderful. This is what we are. We are a communication space here. Everybody has a voice. I see that Elsa also and Ellen lifted their hands. I think.
Yes.
Ladies first, I would say.
Yeah, of course.
Hi, so I'm also a former attendee. I was a member of the last cohort in last September. And so I have a different perspective because before the voice course, I was not an active patient advocate. I was a budding one. And I wanted to say how much this has taught me and how confident it has made me. And to give an illustration of that, I'm now part of 3 patients' organizations, including I became a trustee for one. And I started actually sitting on patient advisory groups only in the past few months. So it's been very, very exciting. And the course has really given me the confidence to step into that role. And also, I had just come to the UK a few months before. I come from France. I was treated in France for breast cancer. So I was a bit nervous about basically finding these patient organizations, finding a way in here in the UK. And thanks to ICPV and to the voice course, I've really been able to do that. And as far as, so you asked, Catherine, you asked, how do we find Dave and ICPV and the voice course? And for me, it was because I was not a member yet of any patient organizations. I was just a patient. I simply Googled patient advocacy, and I went to the UCL-led PPIE Day, and that's where I met Dave and Sean, another member of ICPV. And I simply had a talk with them and said, I'm fascinated about what I've seen online. I'm really curious. I want to see what that's about. And they were so welcoming. And they said, of course, you can sign up. You don't have to be a member of any organization. You can just sign up as a patient yourself if you want to educate yourself. And so that's what I did. I took the week just for myself to get trained and to get this kind of all these skills and all the knowledge that would lead me to confidently step into patient advocacy roles. And of course, I second everything that Peter just said. So we were not members of the same cohort, but it brings back all these memories. It's exactly the same experience, and nothing but good things to say about the whole thing. And of course, a huge thank you to Dave here.
Yeah, well done, Dave.
Thank you.
Now I would like to give the mic to Ellen, and thank you, Elsa, for your explanation and for your sharing your thoughts. It's beautiful to hear. Now, Ellen, it's your time.
Thank you,
You've got
Catherine. I've known Dave a while. Dave and I were started as research champions for what is now the University Hospitals Trust in Sussex 9 years ago, Dave. It's somewhere around that, I think.
Yeah.
And I'd like to talk a little bit about the impact, because without Dave, I also wouldn't have a completely different perspective. I was on Peter's course. I think Stephen Rowley's on the call as well, who was also on my course. And Elsa, it's great to hear your story. That's amazing. I want to bring the course to Sussex, and I'm in advanced talks with the director of the new Sussex Cancer Research Centre and Sussex University, and also the University of Chichester, which is a nursing and allied professional school, where we are really keen to bring research, not just academic and medical research, but also involve the allied professionals. It's opened doors for me. Dave's very modest, he's thrown a pebble in the pond there, and the ripples, you haven't a clue where they've got, Dave. They've gone miles. I'm a public advisor to the Sussex commercial, very new, this is very new, a commercial research partnership. And I'm a public voice there. I represent a rural area with elderly population, because I'm both live rurally and I'm elderly. Also, I sit on the Sussex Health and Care Research Partnership as a public advisor, and we help to design their PPIE strategy and how they might move forward with that. Last week, I was at the Macmillan Centre in University Hospitals in Brighton, where we held a science cafe, and where I actually felt that I knew what they were talking about, thanks to Dave and the IPCB course. And that has led to involvement with young people. A breast cancer survivor who wasn't believed when she first came forward with breast cancer, because she was only 22, I think, when she was first had the symptoms, and nobody believed that she had it. And she's now sitting as a research champion and a voice for that cohort. My interest in cancer, I'm not a patient, I'm not a survivor, but my very best friend and business partner died at the age of 50 from an aggressive head and neck cancer. I advocate for friends and family, although that indirectly helps the patient, as you well know, Dave. Yeah. I've currently got international clients. I'm out in the Philippines regularly, not myself, but online, thank goodness for the internet, talking to Philippine support, where the health service is very different, because they don't get any financial support. And also it's rather American-led, which has its own challenges, shall we say. I also have 2 patients currently on their journey. One I think is not a good journey, where I'm trying to support the family there. The real thing is this I came up with the strap line. I happened to write on a post-it note, so I can't really claim credit for it, but it is that today's research is tomorrow's treatment, and that's now been adopted by university hospitals as their strap line. And we're talking about research and innovation, and also quality improvements that have direct impact on patients. The new Sussex Cancer Centre is very exciting, and I've been a participant in trials and a co-production for over 50 years with my illness. So I'm an old hand at this, but I give a short talk about my research journey, which seems to be well received. Short talks aren't my forte, but I've got it down to 15 minutes, Dave. You'll be glad to hear. But I'm being invited to talk about that journey by researchers, by academics, by students. I'm involved in the, and then all this has come from the charity of university hospitals, which previously was Western Sussex, who heard about me and my loss with my business partner, and funded me to go on the voice course with Dave. Peter, it's great to see you. Stephen, I know you're there as well. Elsa, it's great to meet you. And I'm going to shut up and let Dave, because it's not my gig, it's his.
Well, thank you, Alan. I don't really know the impact the voice course makes. I see these people. John Marshall sees people. He's the other person at Barts who helps run the course. He sees people everywhere he goes as patient advocates. He said, "I know you from our course," and that is, for me, is the big thing. I do need to get that impact paper written. It's so I'll be calling out to everybody who's been on that course for what they're doing now and where they went. So that's important for us to record that. But yeah. Sorry, you're on mute.
Yeah, sorry.
Sorry.
Do you hear me now?
Yeah. Yep.
Perfect. Great. It seems like that I thought that this course was for researchers to understand the patients in first line, but it seems like that it works the other way around too. Yep. It helps for you to, so actually this should be available for everyone. I mean, yes. This is medical language is so hard to understand.
It is.
And Stephen would like to say something.
I was just typing something in the chat on exactly this, is that it was originally set up to provide education for PPI that were involved in research trials, because the trials get more complex and the science is more complex, and PPI, quite often I've met PPI who just sit there and nod, because they don't really understand what's going on. Whereas, that's no good to researchers. They need PPI who are going to be engaged. And also from patient perspective, generally, they need PPI who understand what's happening. And this course certainly does that. It certainly provides a very good understanding of how cancer happens, what drives it, what are the characteristics of its evolution and development, and then what are the techniques that are being used to address it, and the research involved in that. But as Alan so clearly demonstrated, yes, there are now lots of people who've been through the course, because it started in 2014, was that right, Dave?
2013.
2013.
Yeah.
And such is the good grounding that people get on the course, that they're quite quickly picked up, and then they move up into other roles in PPIE. In in the UK, people get involved in the different kinds of boards and committees and the like. Most to do with research, but often to do with other things, like policy and other aspects of provision of care. And I certainly found that, for me, when I did it, it certainly gave me a boost in working. Yes, I'm involved in research, but also I'm involved in policy and stakeholder on the National Screening Committee, and also internationally, very interested and involved in policy development in Europe. So, and now I'm working on developments in sub-Saharan Africa and the like. So, it's a good grounding, and it gives you that biological grounding, but it also then develops a platform on which you can then build broader PPI involvement.
Yeah, thank you. And the last few years, it's actually what we've seen. It's changed from not just being the patient advocates learning, it's researchers learning from us. They this year, last year, John said, "I don't know about that. I have to find out." And they are learning from us. And the people in the labs who teach us, show us what to do in the labs, they're all students. Often their first contact with patients in the work. So they're learning from us, and it makes a huge difference on how it runs.
Yeah, I think it's good for all sides to learn the language of the other ones, right?
Yes.
If you ask me, this should be a standard program in every medical school, and also a standard program worldwide. That I'm multilingual, that I come from the translation sphere, and for me, it's always also really important. We have a lot of resources in English. It would be nice to have them in more languages to give more people the opportunity to understand what's going on. There is, and then that's also localization is a big thing. I just learned, my book How to Speak Cancer is translated into Urdu and that's a language you speak in Pakistan. And I just had a chat with my translator the other day, and he said that usually in Urdu, or in Pakistan, the people don't even learn they're diagnosed. They don't even get told that they have cancer. They just get told you have a fever, take a pill, and then get on with it, So this is where they stand. And I know that this is very, very different in all the kind of languages and cultures. So I would love to see this course like worldwide, adopted, localized, translated. I'm such a fan of this idea and of bringing together. This is exactly what I want. I want to bring together the science and the patients. And this is also why I was so over the moon when we had our talk last week, Dave, because I didn't even know about all this. When I ask you, what would you wish for the future, for all your organizations you're working in? Oh, sorry, I just see Peter held up his hand. Before we answer this question, I don't want to.
Yeah, no, I
you.
mean, mine was just a very simple observation on what both Alan and Stephen has said, both of whom I know. I think the one thing it does do for people doing PPI, I mean, Dave and I, we can talk for England. We're very gregarious. We get out there. We'll get in there and we'll fight. And Stephen also, you know, and Alan, we'll get in there and fight for the patient. There are, as Stephen said, there are a number of people who take part in PPI. They perhaps don't have that self-confidence. They're a little bit concerned about challenging. They don't understand the terminology. And one of the things that this course does is it gives you that. I think it gives people confidence to be sat in the room with all these white tower folks and be able to sit. Yeah, well, I didn't quite get that, but I drew just enough. Right, I'm going to ask this question, and suddenly they will ask the question that actually challenges the speaker, because suddenly they're thinking, well, hang on, yeah, I did just say that. What did that mean? So as much as anything, it gives you confidence to stand up and challenge the things if you think it's not right. That's how I see it as well. But anyway,
absolutely,
I'm going to shut up.
You're absolutely right, Peter, because what I also observed as a nurse often was that patients don't dare to ask the mighty doctors. They are up here and the patient is up here, down there, and we nurses were somewhere in the middle. So we were always the ones communicating, like the translating, you know, the HCP language and the patient language. And for these courses like this are just brilliant, really.
They are, and for the future, it's not just about the voice course. It's about every patient advocate out there being able to use their lived experience to have a voice. And it's the voice course. We have to pay for it. There's accommodation, there's food, there's other bits and pieces. So it has to be paid for. I would love to get funding to make sure it is open to everybody, wherever they are, in any language.
And therefore, it would be great to have this umbrella organization, and then from there go into the different languages. So if we just imagine that this course would be offered, like a course concept would be offered, and then it can be sold into medical schools. I read in the chat PhDs. Yes, of course, nurses. Even there are nurses who don't know how to communicate properly. Everyone who has a voice on the HCP side, clinical researchers, everyone should get access to that course, and it should be a basic education materials, basically, right?
That's it. That's what I'd love to see.
Yeah.
And it's when we run the course, when we take it to other countries, it's the researchers in those organizations, in those universities, are then now learning how to work with patient advocates. It's a big learning curve for them.
Yeah.
It's not just for the patients, it's for the organizations as well, on how to set their mindset to working with patients.
Exactly. I was just going to say, it's not just the language. It's also the culture. It's the understanding of the patient's mindset. It's the understanding of where does the patient come from? What does he feel? What does he think? Right? Yeah. Stephen, you would like to say something?
Yeah, I think there's something underlying which relates to all this, particularly, and David will know this in particular because of the European aspect, is that the EU has a I can't remember what the actual term is, but they've got the human rights for cancer patients, and within that is written the commitment to co-creation or co-production, that patients and patient organizations should be involved in the research, the developing co-creation of the research and services for patients. And so to be able to co-create, you've got to have patients who are confident about the role of the patient in those organizations to be able to do it. And so I mean, there's still a lot of research that goes on where they don't understand what the PPI is for or whatever, or why they have to put anything about it in their funding application. But you know, it's now an essential part of many funding applications that you demonstrate how the patient voice is going to be part of the development of that research. And increasingly, well, especially for the big ones like cancer grand challenges and things like that, it's absolutely essential. But that's trickling down, and I'm getting to the situation now where I'm actually just writing this morning. I've got to finish it because deadline's today. A proposal for research where I'm writing the research questions.
Well, that is amazing.
And already been told, you know, the topic is good. If we do a good application, I will get the funding for it and roll out.
Wow.
So that will be, it's in collaboration with a professor at local university, and it will be a patient-led piece of research. And I think so that you know, this is research that I as a patient realize that needs to be done in order to ensure the right services get delivered. It's not about research into you know, techniques of treatment or anything. It's about developing appropriate evidence in order to support the funding of you know, particular kinds of services, and it's in behavioral science, and you know, and it's applying for you know, health psychologists to do the work. So you know, that's how much things have changed. When I first started doing PPI in the teens, 20 teens, it was nearly all reviewing patient information sheets. Now we write the sheets. In fact,
that is amazing.
We write. So one of the big projects I'm saying is, well, patient sheets okay, but we need a website.
Yeah.
So you know, I'm helping run the team to set up the website.
Wow, that is amazing. This was actually one of my last questions for Dave, or then all of you, because I remember when we talked that you were so positive about the development of the PPI in the industry, and I wanted to ask exactly that. How do you measure that? Where do you know why are you able to say that? Because sometimes it feels like you're fighting against windmills when it comes to patient centralized writing, right?
There's a lot of research I'm seeing now where actually they come to us right at the beginning when they're developing the question, and we're changing the question slightly to suit the patients, what the patients need. And
that is amazing.
There's a lot of researchers who understand that now, but there's still barriers. A lot of the work I did with NIHR on the funding panels, you talk to a researcher, a postdoc, you know, and why haven't you got your PPI? Because my supervisor said I don't need it. It's scientific research. It's not clinical. There's still those barriers out there from the established.
Yeah.
Some of the really top established researchers, not many, but there is still the old school barrier.
Yeah,
we're not needed in the research.
we have always done it that way. It always worked, right?
Yeah,
Yeah.
yeah.
Yeah. Slow progress, but it seems like there's a good progress. Like you here sitting here, it seemed like you're quite happy with the development of the PPI. Correct me if I'm wrong.
It's changing. It's getting better. I did have a concern recently with a couple of posts put out by NIHR that we hit the plateau and we're falling off the edge, but I don't think we are. I think we've just hit a stage where we're being more accepted.
And why do you think that is? What happened? Why is the change?
Why is the change? I think they've just suddenly realised how much we can offer into their research. That lived experience we have is, what they're doing is to benefit patients, and they need to hear what benefits the patients. Yeah. Not just think it's their question. And
absolutely.
So it's for me, it's changed completely, and it's huge at the moment. And
I'm really, really glad to hear that. Now I'm curious what Alan has to tell us about it.
Yeah, I just think that an awful lot of it is that you mentioned earlier, right at the start, Catherine, you said about the researchers having a story as to why they're involved with research. Well, the patients have got a much more powerful story about why they're involved with research usually, and that's beginning to be seen on an equal footing. So the lived experiences are valuable, they're needed for the funding, but actually, you're dead right. The relationship I've got with the University of Sussex and of Brighton and of Chichester, they want to hear that voice because it means something. That it's all measured by impact. It's all measured by delivery. There's now a research delivery network as opposed to anything else, and they really want to see what the impact and the delivery is. And the boundaries are blurring. That boundary between pure medical research and quality improvements, it's innovation and it's patient story. I put in the chat about healthcare professionals and healthcare workers. One of the very simple ones that has had a major impact and is likely to have a national impact was the way that nurses make beds. Now you'd think that isn't a research project, but my goodness, what a difference it makes if you batten somebody down by making the bed the traditional way. Their mobility is affected. It affects certain conditions where they can't help. Some very bright healthcare assistants who was making beds all day said, "Why do we do it this way? Why don't we do it a different way, where people can actually get out of bed and be mobile and not be strapped in by the traditional bed making style?" And that has a huge impact on patients. Another one was your trust, David. I had an operation there recently, and I was approached by an anaesthetist who said, "Would you like to be on a clinical trial?" Not having a clue about who I was and the background I had, and I said yes. And he had, again, it was a theatre nurse who had come up with, why do we always make people sick in the recovery room? Why are they always feeling ill? Well, it's to do with too much water and also sore throats from intubation and things like that. So they came up with what they call the popsicle trial. Dave, I don't know whether you're familiar with it. It's great. They offered that to me. Unfortunately, I was on the control, so I only got water. But the idea is that you have an ice lolly, a popsicle, and that numbs the throat, so it helps to avoid patient pain if they've been intubated, and it regulates the amount of flow. Two very, very simple projects that have major impact, not just in the Royal Surrey, which is a wonderful centre, by the way. I'll sing its praises all day long because I've had treatment there recently, and their robotic surgery unit is just amazing. But they're all research ready. They're all research involved. They all want to hear the patient voice. I was invited back to speak at the open day, Dave, and I went into the theatre where I'd had the operation only about 3 weeks before, and talked to a whole cohort of patients who had come to view the new robotic surgery. And I said, 2 weeks ago, I was lying there, and look at me now. and able to speak from lived experience. That's where the power is, because the theatre nurses said, I've never seen a patient before. They come through and they go and we never see them again. And it's that connection, it's that understanding of the impact of what they're doing. It's the same with treatment as it is with research, but I've said enough. But we're all passionate about it. It's lovely. I love to
I know. I love that too.
Passion.
I love that too, Ellen. It's funny what you said about the ice lollies, because that was in the hospital I worked, standard procedure. We did that all the time, especially for that reason. It was such an easy thing to do, but with such an impact, right? Yes, let's Peter, you've got a mic. Sorry.
Sorry, I said I could talk for England like Dave, but I'm trying to stay on topic. But it's interesting. That's interest. But yeah, I mean, what Steve and Dave, Alan particularly outlining there, one of the things that I've noticed with the researchers is, as research is developing and they're starting to home in on specific areas. Now, for instance, breast cancer, a few years ago, if you wanted PIP, you might go out there and ask for women who have got breast cancer to be part of a trial to review documents and give an input. I got asked by one of the people I work with if I would support a postdoc at QMUL this week working on prostate cancer, and her little team, we're trying to get the bid put together for her, but they are focusing on such a narrow target that we've got to go out to the consultants, because going out to PIP groups and the rest of it, you won't get the people. So I'm going to try and support her by going out and actually talk. Fortunately, I know some consultants, so I'm going to go and talk to the I'm going to try and contact the consultants and get them involved, because GPs and PIP groups just won't be covering this particular specialist area of prostate cancer. So yeah, it was wide, the pyramid, it's a bit like Maslow, isn't it? You've got this wide pyramid at the bottom, but actually as it goes up, there's less and less people able to support that research, and this particular one is very specialized. So that's all I wanted to add, really.
Well, thank you, Peter, for pointing that out. What I believe why it is so crucial for researchers also to have the PPI included is that it makes it much more trustworthy, and it might help to get people to stay in a trial, because I mean, that is one of the biggest problems for researchers, that people drop off and that they don't feel included enough. And I think researchers can and pharmacies can only profit from listening to you and including you, right?
Sometimes we talk too much.
No, I cannot imagine that.
As you can see, that there's many of us out here doing this, involved in, like Elsa, she was new in September last year, and she's now getting involved with 3 organizations. So well done. That's what it's about. It's my aim is to help everybody get their voice, use their lived experience to get their voice, to be able to, and then pick and choose where they want to go with that voice.
Exactly. And then also it needs to be diverse, every age, every gender, everything has to be, every social background has to be included in studies, and also in these communication groups, right?
Yeah, it does, very much so. So I think we've overdone.
I think we are on a really good way here. It's such a nice discussion group here, really. Is anybody else here who hasn't talked yet who would like to give us a comment or would like to ask a question? Because we're nearing the end of the Met Talk. Anybody else? No, it's all said. Wonderful. Yeah. Well, I hope that I know we will stay in touch. And Ellen, Peter, Stephen, please, Elsa, get in touch with me on LinkedIn. I would love to stay close to you because I really like your opinions. And I have some initiatives myself where I would like to invite you to. And everybody else here who hasn't talked, of course, you are also invited to get in touch. Wonderful. This said, I would like to thank you, Dave, and all the others for sharing your opinions, your voice here with me, sharing your time. I really appreciate that on a Friday afternoon, or yeah, for me it's afternoon. And I would just like to say again, if anybody would like to explore some sponsorship opportunities, I'm here, you know where to find me on LinkedIn, on my website. Otherwise, I hope we stay in touch and looking forward to more conversations. Have a great rest of your day all together.
Good to see you, everybody. Bye.
Bye.
Bye. Great to see you, Dave.
Bye.
Bye.